And then if we could start with some introductions of the ECHO team. Renee, would you mind introducing yourself
Not
again?
at all. Renee Bolio Banks, Indigenakaj, Aganashimang, Zibikwe Indigenakaj Indigo, Zagaswa Jamaica, Ganjunjaba, Magazine Indu Dame. So that's kind of a typical greeting that we use. I'm Anishinaabe from Leech Lake. My birth name is Renee Bolio Banks. My spirit name is River Woman, and I'm from the Eagle Clan. I've been at NACC for about 6 years next month, and I'm really glad to be here and so honored. Miigwech.
Miigwech. And Dr. Robbie?
Yes, Miigwech Renee. My name is Kari Robbie. I'm a family practice and addiction medicine physician. I've been at NACC since 2012. Thank you all for joining us.
Miigwech. And Nikki?
I'm Nikki Jardina. I'm a public health nurse, and I've been at NACC since 2017. Thanks.
Miigwech. And I'm Lindsay Kinkuni. I'm the Harm Reduction Program Supervisor and also coordinate the Midwest Tribal ECHO with the team. I've been here close to 3 years. Thank you. And so I'm going to share my screen and we'll just get some announcements done, and then I will hand it over to our speaker. Can everyone see that?
Yes.
Okay. So welcome again to Midwest Tribal ECHO. Today we are the Opioid Use Disorder and Education Treatment Series. We are very pleased to welcome Sarah Jane today to talk to us about care and proximity to drug use. A little bit about NACC, if you're not familiar. So we are an FQHC that was established in 2003, located in the urban Indigenous community in South Minneapolis. There's a list there of all of our services that we provide. And then our website is listed down at the bottom if you'd like to learn more about us. This is a list of current open positions at NACC. Again, our website is at the bottom. So if you know of anybody that would be a good fit for these positions, feel free to direct them to our website, and you can go to the job section and read more about them. Some session guidelines. Please note protected health information. We would love to see your faces to engage during this time. So if you're willing and able, please feel free to turn your camera on. If you can let me know who you are in the chat, your name, title, organization, and email, I can email you information from the session. This is a list of other ECHOs that we recommend that covers similar topics on opioid use disorder. And then announcements. So we meet the first and third Wednesday of the month from noon to 1 Central Time. And our next session is going to be Wednesday, May 7th. And that's going to be on opioid use disorder care in the emergency department. And then finally for me, so case presentations, we welcome if you have any examples. They make for great discussion. Any difficult cases or success stories, feel free to email me. My email address is on the slide there. So thank you. I'm going to stop sharing. And I'm going to hand it over to Sarah Jane. Thank you for being here and welcome.
Yeah, thank you. Yeah, I feel really humbled and with a lot of gratitude to be here. Lindsay reached out to me yesterday and was like, hey, would you be willing to present? Usually I have like a task at hand, so it also is like an edge for me to be presenting just about more of like my education and philosophy and things that are really close to my heart. So with that, I also just want to lift up being in relationship to each of you as caregivers and in a practice of knowledge seeking and knowledge production that we're here today. And grateful for Elder Renee to bring in that it's really important for me to acknowledge my place in South Minneapolis and just a few miles from the confluence of the Mississippi and Minnesota rivers, the Waukpatonka and Minnesota Waukpa River is a place that has known to many as Bedote, where in 1805 the US signed a treaty with the Dakota leaders to build a military fort. And I'm just a couple miles from there. I'm in proximity to Lake Street and Chicago Avenues, and I travel Franklin, Bloomington, Nicollet, Hiawatha, and Cedar often. These create arbitrary borders in East Phillips, which currently experiences our highest concentration of involuntary displacements of those in our city who lack residence. I'm a public health nurse. I work in proximity to what my public health lineage calls marginalization, specifically at the intersections of clinical health and medical services, housing deprivation, and the criminalization in proximity to illicit drug use. I get more tongue-tied when I am on Zoom, so just appreciate your patience with me. And I'm going to share my screen here. Do people see my whole desktop background or just my slides? Okay, great. My name is Sarah Jane Keaveny. I use she and her pronouns.
Jane,
Yeah.
I think we're seeing presenter view.
Oh, great. Let me just see
There
if
we
this
go.
resolves that.
That's better.
Yeah.
Thank you.
Great. So this I'm calling care in proximity to drug use. Our objectives today, I want to talk about our proximity to drugs, proximity to care, our care in proximity to drugs, and then review this Madeleine Leininger's cultural care theory. Lindsay asked if I could talk about what I studied with my master's degree. So we're going to geek out on some nursing theory. Just a strong shout out to all the nurses in the room here. A lot of acronyms on this page, a lot of kind of like buzzwords too. You'll hear me describe people marginalized by drug use or people in proximity to drug use, people impacted by the criminalization of illicit drugs. That's really specific for me. I think that in community, I'm working around marginalization that's not just individualized, like a person. And so really wanting to talk about this in community and in conditions and not just as individuals. And then also this distinction about between community-based networks of care and clinical medical health settings. And then, yeah, some other themes from harm reduction and transcultural nursing. And this person, Madeleine Leininger. My background is a public health nurse in proximity to the Native American Community Clinic, working in close relationship over the last probably 8 years through multiple outbreaks, hepatitis A, HIV, really increased cases of other infectious diseases. And then currently as a consultant as NACC is expanding mobile medicine into the community. I was one of the first folks that was kind of like designated to be a professional in response to the HIV outbreak in encampments in Hennepin and Ramsey counties, and really was around to understand how public health was identifying HIV risk factors and in community, and really looking at this little map that we have here, all of the existing agencies and entities that have been long-standing in the community doing response in community, in connection, and in relationship. And then also there, I think, will be a time in the future where we may overlay some of the also impacts of involuntary displacement that's happened in the community, and just looking at how the relationship between those have impacted communities, especially folks who sleep outside. But that's how I, yeah, I don't know. I want to use like some word like got my chops or something like that. But really, I think it's more came into relationship with some of these complex ideas, and then the care networks that I have really just learned so much from and in relationship to. I am not an expert at many things. As I said, like my background is in public health, but I really value coalition building, community engagement, centering people with lived experience, and this idea of relationship-based care. I rely a lot on knowledge exchange So I have some knowledge as a clinical health and medical provider. And then I also know that I am in a knowledge-rich community, especially when I'm in communities that have the most barriers to accessing clinical health and medical services. There are deep networks of care. There are really powerful ways in which people care for one another and engage in community. And that exchange of knowledge is really important to create kind of like what I come to understand as like a sweet spot for where we can transform not only like clinical medical services, but also bring resources to a knowledge-rich community. So that idea of being intersectional and not an expert is really important to me. As a caregiver with medical professional, I have access to knowledge, practices, resources that can improve, inform, and empower the health ways of people in proximity to drug use. And I acknowledge that in a person in proximity to drug use, I have access to knowledge, practices, resources that also can improve, inform, and empower our clinical health and medical settings. I am also not an expert on this slide. These are falsies. These are eyelashes. You can like purchase them. I understand that there's like many different kinds of eyelashes that you can purchase, you can use. As a parent, I learn more and more every day about what I don't know, and also this concept of cringe. And I think that this slide in particular is my cringe slide. I am not pretending to be an expert on eyelashes, but I love hearing people talk about them. I love thinking about like, what do you do when your glue falls off? Who do you get your falsies from? Which products do you prefer? How do you feel when you're using them? How do you feel when you don't have access to them? Who are your biggest influencers? And I think people love to talk about what they're passionate about and what makes them feel themselves. And I think that we can have as open and like delightful conversations about injection drug use as we do about eyelashes. I will share with folks this dialogue for injection drug use. This is also a conversation starter that I love to use with people. And now it's kind of like this idea that's at the back of my mind when I like come to like that impasse of like, I want to know more, but I don't know how to ask. I think of like conversations that I'd want to have about false eyelashes. And then I kind of like apply that, like, tell me what you want to have access to when you're using. Tell me about how you prefer things. Tell me what your preferences are. Talk about yourself as an expert and tell me like what makes things feel best for you. Can give me a lot of information for a person, like how they're caring for themselves, how they are in community, how they are in relationship to one another. And again, like I said, I'll have Lindsay send this out to folks. And this is like one of the tools that came from my education in studying with this person, Madeleine Leininger, really looking at viewpoints and values, that culture and values and goals about healthcare are people's expression of their sovereignty, of their autonomy, and of their personhood. And that is a gift when they give those to us, and that we can be engaging with that. So just, again, bringing her in. And then I want to talk about this kind of like bigger concept in harm reduction that I think a lot of people have heard about. The credit goes to this guy, Norman Zinberg, who's from Yale University. And what I thought was the origin of this was, so are folks familiar with this? It's the idea that an incident of drug use is impacted by what drug, and like all we can know about that, the concentration, the clarity of the drug, as well as what is the setting that the drug use is happening in. Does a person have control over that? And then the mindset of a person as well as the effect of the incident of drug use. But what I came to find out is that his motivation really was about the stigma that was around illicit drug use and how that impacted things. So both like really lifting up this idea that the social settings and the legal attitudes about drug use that were present in the room when like an exchange was happening also was a determinant about how the exchange was going to go. So really engendering some of the fears that undermine our capacity to relieve suffering in community. And then also this invitation to look at the knowledge that is like the impact of stigma and what that does to knowledge when it's in the room. stigma in general, I got to learn a little bit more about when I was invited to go to the Escalate training. And this was a tribal training around HIV stigma in particular. And this slide kind of like helped me shift again my mind about what really the role of community-based networks of care can be in relationship to drug use. So this is a slide that was presented to a group of infectious disease, like healthcare providers, really looking at what is our stigma when people come into our care and what is our understanding of like a person's access to treatment or right to treatment or even just like value inside of the room. And it was a really like transformative room to be in when people were acknowledging that, yes, it is different to know transmission, like how transmission happened. And then again, just being in solidarity and relationship with people who use drugs, recognizing that that voice oftentimes is another impact in the room and what happens when we are accessing specialized services and need to be referred again to another specialist or another provider or some more complexity brought in where yeah, stigma can just rupture so many things that are possible in an exchange. So looking at how most service models and practices have a history of being separate from drug use or trying to orient themselves in proximity to abstinence or away from drug use. This is a slide with a lot of words. I'm not going to read it, but this is the abstract of like the big paper that I wrote at the end of my my dissertation that really is talking about the knowledge and careways of people marginalized by drug use must be integrated into careways of clinical health and medical settings to advance health and prolong life. And that really is my goal. I want to make sure that people not only have a chance to do knowledge production and like this empowerment and that we're aligning our values, but that we are actually prolonging life, that we're ending violence, we're coming into this present moment, like what is in our room, what is in our community, what is driving on these streets with us, what is like here with us, and then creating the conditions that can shift histories. Like knowing the place that we're in and our orientation to this place and the long history that we have with displacement and the criminalization of drug use and our communities, I think is really important as we approach this work. Okay, ready for some nursing theory? Leininger came up with this like really advanced kind of like complex model. You can see all these like factors that move around there. But really her idea is that we are impacted by land, we are impacted by work and economies, our bodies are impacted, our spirits are impacted, and that this is an opportunity for more of a desired-based framework. So moving away from this concept of marginalization and into like a complex personhood. So it moves kind of what's we in kind of the medical or science models would say are unknowable or unknown, what's hidden, and then being able to pull these into places where we can really understand them. We can understand them as foundational components of someone's experience. We're acknowledging experience as a tool, ideas, ideologies, impact, our intentions, are also part of our human agency and our sovereignty. This is the model that I applied from Zinberg's kind of drug set setting. And if we overlay this kind of with some of those ideas of stigma that we talked about before into our clinical health and medical settings, we actually can look at some of the things that we think might be unknowable or unseeable and start to acknowledge like, what does this mean when a person comes into care? This slide used to have a big word on the top that said contingencies. And it's like, I love thinking about like, if I'm talking to someone right now and I'm like, hey, do you want to go to the clinic? There's a time next Thursday at 2:30. Do you want to go? They're like, yes, I do. And then I think about all the things that are going to happen between now and next Thursday at 2:30 that are going to make it possible or impossible for a person to be at this event that they really authentically want to be at. And for a long time, I used to think about contingencies as like strictly about the conditions and strictly about just kind of like all the barriers. And in doing this work, like really shifting this idea and coming to understand better the definition of contingencies. Contingency is like this old Latin word. Contin means like coming together, and agency, like can our agency come together? Are we going to be able to meet in this like unknown future? I think about agency like as a very personal thing, so an individual's agency, but then I think we can also think about it as our agencies, the institution and organizations that we work with. How are our agencies making our, connection, like the possibility of connection, available with the most agency? So an invitation to explore, like, what is it for those that we engage with? And then also, what is the mindset of the agency that we have? Like, what are the attitudes and approaches? What are the goals? Are goals abstinence? Are our goals kind of like to deputize our workers so that we're getting information about drug use without getting knowledge about drug use? What are the policies, practices, and norms? What is the implications of these? And then what are the setting? Like, is this a clinic? Are we at the bedside? Are we in the community? Again, all of that is like that sweet spot in the middle of like what the effect of a person entering into a healthcare setting. What is the outcome on relationship and impact? And I apologize, I don't have access to the chat right now. I hope there are questions and conversations that come from this. This is a slide, just like a nod to some of the stuff that is to come. My project, or like my program, like the educational formal education ended in 2023, and I have been really honored to be invited into the work of Project Build, as well as some other really cool work with the Cultural Wellness Center. But all of this is doing participatory research and knowledge production. And then also in consultation with NACC as they're expanding their clinical medical services and the mobile medical model. Project Build is looking at health impacts of involuntary displacements, or known as encampment clearings. And this is really like another area that I think we recently completed 12 months of collective knowledge production. And all of this was done at local libraries and with rooms full of both service providers and community members. And the official data is not yet available, but as of November, what this slide is showing, November 2024, our halfway point, Project Build has demonstrated 65 distinct displacement events, totaling in 2,265 impacted individual actions. So an individual may have been impacted a number of times, but it was specific events. And yeah, Build is a project of, researchers, collective researchers, service providers, community members seeking to better understand displacement events in Minneapolis, using citizen science to collect data and hosting monthly meetings to convene with community networks of care. And really that idea again of advancing the knowledge and care ways of those that are most impacted and who have the most knowledge who are in the room. This kind of brings me to my last slide. This is a nod to the instructors I studied at Augsburg University who really held this value of the citizen nurse, co-creating, de-emphasizing the expert model, and practicing from a social justice framework. And that's the end. This is a sloth because it took me a really long time to complete my program. This is Chloe from the Como Zoo. I don't know if anyone knows this, but she recently had a baby. It was a surprise to the zoo and to the folks that were there that day.
Love it. Thank you so much. And I was just looking at the chat. Does anyone have any comments or questions? I haven't seen any pop in yet, but please feel free to come off mute.
I have a question. Sarah Jane, are you familiar with the concept of ROSC, recovery-oriented systems of care?
I have heard of that. I'm not like deeply familiar with it, but what strikes you as like a connection to that?
more going beyond person-centered to integrating the care, not just into the community, but out of the just differentiated setting that has always been present for substance use. I just received something today that showed that people here are looking into that further. So I'm going to ask that they send you that as well. I think you would be a huge valuable resource for that.
Well, that's great. And I fully imagine that there's people on this call that are familiar and connected in with that as well.
Yes. Thank you.
Hey, this is Tanya Chairland with MDH. I really appreciated your presentation, and thinking back to that slide, I don't know if you'd be able to bring it up again, but where it showed the 3 big circles and there were different like rainbow colors. You talked about how it's both the individual and the organization. That would be, you know, like considering the mindset of the individual. Yeah, that one. The mindset of the individual, the mindset of the organization, and then all the things around the drug and the setting. I think I'm just wondering how this could be leveraged to like policy change within healthcare systems and potentially evaluated. This seems like an evaluation framework where you could look at these different areas and then kind of see where there are gaps or opportunities for additional training, or even opportunities to like revise policies that might be creating you know, better or worse conditions for the outcomes that you're hoping to get. So I see this as just like an amazing evaluation framework as well as a policy change framework. And I was wondering if anybody is, you know, if you've thought about that, or if anybody's been connected to work on that, maybe. I think there's a lot of potential here to improve our healthcare systems.
It's having a really hard time figuring out how to come off mute in this. So I, in my spare time, would love to be doing that. Yes. I think that there is, to your point, a really, it maybe goes back to something I said on the front end. I think I have had such privilege of being in deep relationship with people who use drugs and who sleep outside, and understanding all of the knowledge that I am gaining in relationship there. And I think my edge is being able to understand also how that can work in relationship in clinical health and medical settings, and being able to translate a little bit of that and really shift some of that. Yeah, the agency perspectives like you're talking about. I think that would be really cool. And I think if research were being funded more, or we knew the future better, I'd love to understand how that could fit in to some of the work that's happening right now in our community. I think that's great.
Sarah Jane, I just want to say thank you, and I'm very moved by this, and also so troubled because, of course, the popular narrative is contrary to this currently. Certainly in both communities I work in, which is Minneapolis and the Gulf. So, yeah, I don't want to ask any more of what you've already done, but I'm feeling compelled to figure out a way that this can become something more people hear about, because it's so contrary to what well, certainly our policy practices in Minneapolis particularly are abhorrent, but also I think people don't understand the impact that stigma has on outcomes. And I think it's really vital that people do. So I just want to thank you, and I'm so glad I got this invitation.
Yeah, and to say I would be happy if you have a group of people that you feel would benefit from a presentation like this. I'm happy to get connected. Yep. And I don't have anything more formal to like link it to, but I did put my just a Gmail email account, and I'm happy to follow up with anyone that would be interested in it.
I can also send out slides from today too. And then I was gonna put, Sarah Jane, you had the dialogue for injection drug use document. I'm just gonna put that in the chat for people to take a look at. I'll also attach it to the email with the slides. I don't know if you wanna say anything more about that document that you sent over, but I just put it in the chat.
Yeah, that's great. Again, kind of like going back to the bigger like project that I worked on, or what was part of that was coming up with an intervention. And to your point, oh gosh, I lost track of your name, but I recognize you from MDH. Tanya, the idea that wanting to create tools and wanting to break down, not just like acknowledging the stigma, but giving tools to healthcare providers, like in clinical settings, of how to approach that conversation. So bringing a package of falsies and, you know, talking about that, and then talking about syringes, and then talking about drug use, I think could be a really powerful tool. And then really recognizing that just the dialogue, and so coming up with the conversation starters was kind of the first step in that. Yep. Well, again, I just appreciate all of the people that are on this call. I've learned from so many of you and a lot of really familiar faces. I hope my voice wasn't too wobbly and that it didn't show that I wasn't like really present here and engaged with all the ways that we know how to take care of one another, and all the ways that we're coming to really acknowledge what we think we don't know as actually really important knowledge. And it looks like maybe there's some challenges to opening the PDF. I'll see if I can attach it here from my end. And
Thank you. Sorry about that. I'm trying to.
Or we could send it out with the slides too, maybe, if that's easier.
great.
Yeah, I'll definitely do that.
Thank you so much, Sarah Jane. It was really refreshing to have that perspective.
Yes, thank you so much for joining on such last minute notice. We really appreciate you and your an inspiration to the work that we do, truly. So I really appreciate it. And thank you, everybody. Sorry, I was having some technical difficulties with a few things today, but I will make sure to send out the slides. Any information that you have, please ask questions. I'll can get you connected to Sarah Jane, and then also all that PDF document that I wasn't able to get into the chat. So sorry about that, but thank you all for joining today. I think we'll get some little bit of time back. And then, yeah, next session will be May 7th. So hope you can join us again. Thank you all. Have a good day.